When placing a nasal airway, this can be accomplished by measuring from the nose to the ear. The bevel is always placed towards the septum. So typically, it's going to go in through the right nair. You're going to be doing this parallel to the hard palate and following the anatomical curvature until the flange rests against the nair. If you have to go down another way, so, perhaps because of a blockage or injury, you're going to still keep the bevel towards the septum, still keeping it parallel to the hard palate, placing until you kind of hit the curve of the airway, rotate in place, and then place to the depth of the nair. And removal is always still along the anatomical curvature.
Positives to this particular type of airway is that the patient can still have a gag reflex when you're placing it. So this is great when they have altered mental status but they're not completely unconscious, or they might return to consciousness, like in the event of, say, a seizure. They may become conscious, and we don't want them to reject the airway. If we have a patient who doesn't have a gag reflex, and a quick way of testing that would be taking your finger and running it across their eyelid, and you're trying to feel for, as well as see, twitching of the eye, because that's the corneal reflex. If they have a corneal reflex, they'll almost certainly have a gag reflex. We don't want to place an airway in that case, because we don't want the patient to vomit and potentially aspirate that. So we verify they don't have a gag reflex. We still have our gloves on. We will have oxygenated the patient, hopefully for 2 minutes if at all possible, but we're going to stop our ventilation to do that. You can usually select a couple different approaches. Usually take your non-dominant hand, and that's the one that's going to help open the airway. In this case, I'm using a scissor method initially, and then there's another one where you can stick your hand down into the patient in its mouth, grab the tongue, hold it against the jaw and open and place. From this angle, it'll be hard to see. I'm going to switch hands so it can be a little bit more visible, as well as there will be an additional view from above. In this case, you still put your hand in, stabilize that tongue. If you're doing, say, the 90-degree approach, you can place into the corner of the mouth, place to depth, and turn so that you see that the flange rests at the level of the teeth.
In the event that you're using a basic oral airway, still measured from the corner of the mouth to the ear, you can place by kind of doing a scissor move, index finger against the upper teeth, thumb against the lower teeth, get that mouth nice and open. You can do a 90-degree placement. We're going to come down the side of the mouth and turn so that the curve points down towards the feet, down into the larynx, and the flange rests against the teeth. Removal is always done along the anatomical curvature and placed and removed as such. There are other ways to place these airways. You can grab that tongue and press it into the jaw and lift, still do a 90-degree. You can get the mouth very open, place upside down until you reach the back of medial resistance, and then you can rotate in place. It's very difficult in this mannequin simply because of how rigid the airway structures are. It would be easier on a person. A third option, if you have a tongue blade or a tongue depressor, is to place that tongue depressor in the mouth, hold the tongue down, and use place in an anatomic manner, keeping the tongue in place so it doesn't get in the way, and it actually stays hooked by the oropharyngeal airway.
Athletic trainers can also place a third type of airway, and this is called an advanced airway. It's a very specific type called a supraglottic airway. There are more advanced versions that involve visualization. Most of us know this as intubation or endotracheal intubation. This can only be done by a paramedic and higher, nurses and physicians, for example. And then there's surgical airways, which are well outside of an athletic trainer's scope of practice. But a supraglottic airway or a non-visualized airway, such as the King LT, provides an option for very good control over the airway without having to become incredibly invasive. However, these can only be used in patients that are not breathing. So these are going to be patients, for example, that are in a prolonged cardiac arrest. Would be an ideal use for this type of airway.
If you're going to end up using something like an advanced airway like a King LT, it's a non-visualized airway, so it's not the same as endotracheal intubation, but it still gives us very good control over the airway by isolating the oropharynx from the esophagus. Essentially, air can only go down in and through the glottis. To place this sort of airway, you'd have it in your dominant hand, and your left hand, in this case my left hand, my non-dominant hand, will be the one that helps open the airway. To prepare this sort of airway, you'd first make sure that the balloon's inflated properly with air, no leaks or anything like that. We'd also be wearing gloves. You'd put lubricant, a small amount goes a long way, so that you want the airway to place itself nice and easily. The amount of air required for each type of airway is typically printed on the lumen, as we can see here. This one would take 60 to 80 milliliters. We're going to place and check and make sure that they inflate. Get the syringe to seat. You see that the balloons inflate. We're going to take that air back out. To place this airway, or this sort of airway, my preferred method is to put the thumb down into the mouth and secure the tongue and jaw and kind of open that airway. Other people do prefer the scissor method. Go with what works for you. Control that airway, open. You're going to come in through the right side or that right corner of that mouth, or if you're left-handed, the other corner. You're going to come down, you're going to slide. The airway should go in fairly easily, and you want to go to the depth of the flange hitting the teeth. Connect your syringe if it isn't already done so, and place the air into the bulbs. Disconnect, and make sure that pilot stays nice and firm. If it's not firm, you have a leak, or you haven't put enough air in. You're going to connect your bag valve mask and give a squeeze. As you can see, there is no chest rise. So we're going to slowly withdraw, squeezing each time. Okay, we're trying to get a little chest rise, but not enough. Well, that's a little bit better. A little bit better. There's good chest rise with good compliance. Okay, we're not having to work hard. We're not working extra. We're not getting any leakage of air around the mouth. You would want to make a note of how deep that placement is at the level of the teeth. It's a little hard to see here, but we're at about 15 centimeters at the teeth. You would make a note of that to make sure that we don't see this tube displace, because we want to still see it and have good compliance. We're getting a little tightness here, so there's our depth that we need. Seeing good rise without any resistance in the bags. You can tape this in place so that it doesn't move. There's a couple tricks to that, and we'll show you that here in a moment. To hold in place with tape, take a little bit of Coach tape, and you're going to tear a little bit, but leave a little bit of a solid start at the front. You can kind of put this kind of starting at the jaw. You bring the other strip around the tube and down onto the jaw. And the other tube can once again just kind of come across and hold. The idea here is that this helps hold the tube stable so it doesn't necessarily pull out. Now, in this approach, you see that you can't necessarily see your markings. You still want to leave it in a way where you can still see where you placed the tube at so that you can check for displacement.
In the event of it being dislodged, the tube should be removed and you should return to using simply your bag valve mask or your simple airways. If the situation warrants, you can attempt a replacement, but the tubes are single use, so you would have to open another. In the event that you have a patient that becomes conscious and gets a return of their gag reflex and they begin rejecting the tube, you can either withdraw through the syringe, but you'll find one of the fastest options is to simply cut the pilot tube, which would immediately deflate it and you'd be able to remove the tube quickly. In doing so, please make sure that you have suction equipment available. They will potentially vomit, and by potentially, I mean probably. Comes out easy. It should be quick. As we said, ventilation should not be interrupted for more than 30 seconds. This ensures the greatest potential for a positive outcome for our patients.